on to the next session, and that is going to be the session by the biotech. So, Doctor, can we move to the next OR?
Mataji, light mein dekhiye.
Dr. Kudlu is here.
Next up, we have with us. Can we change it to the OT1 back, please?
Dr. Amrita, can you please introduce the case?
Yes. So next up, we have with us Dr. Rajesh Sinha, who is Professor of Ophthalmology in RP Center, All India Institute of Medical Sciences, Delhi. Today, we have with him the patient who is a 66-year male being operated for left eye cataract surgery with NS2 cortical PSC, the prominent brow and deep set eyes. The IOL to be implanted is 18 diopters. Over to OT number 1 to start the case for sir, please.
So Dr. Rajesh has been very concentrated. He's already completed the rexes of the patient, and he's now ahead with the hydrodissection.
Okay, so
thank you, Rajesh, for doing the rexes before.
I know, ma'am, that you will definitely thank me for that. And so this is the golden ring that I could create with the hydro. The nucleus is rotating well, and I will start with my P40, vacuum make it 400. हाँ ये ठीक है 300 sorry 400 yeah, and that is 30. Okay, so this is a 66-year-old. Can I have the chopper, please? So this is a 66-year-old male, and a very deep set eye, so you can see sometimes because of collection of fluid, the visibility may be difficult. Can you just hold his head? इसको सिर पकड़ लेंगे ऐसे. हाँ. So 66-year-old male, but considering his age, his nucleus doesn't appear to be very hard. Well, the appearance initially gave this impression that it is not hard, but it is leathery kind of. But yes, after dividing on one side, I could chop it well. After weakening on one side, then I'll rotate it. Then again impel and chop again.
Dr. Rajesh, Dr. Amit here. You usually do primary chop only, or?
Yes.
Okay.
Dr. Amit, good afternoon. I saw your deferred live, and it was fantastic. So
thank you, sir.
And so I've just divided the nucleus into 6 pieces. Can I have the IP on, please? IP on हो जाएगा?
So IP actually gives you a better followability always. So when you've made those pieces and you have to actually actually emulsify them, then the followability with the IP is always good.
So once it has been divided into multiple 6 pieces, you can start the intelligent phaco. Now, before making pieces, it is advisable, you can, but it is do with IP, but it is advisable not to start intelligent phaco, that is longitudinal as well, because the fold will not be that great. But once you have divided it into multiple pieces, you can go ahead and use IP and finish it off. And this is the EP nuclear plate which has come up nicely. And now, Babaji, सीधा रखो please. बस. Yeah. Now आइए, coaxial. So as in the morning I could see Dr. Namta, can I have the methyl cellulose? So I'll just put little bit of methyl cellulose in the anterior chamber. This is the only time when I put little bit of methyl cellulose because the chamber was becoming a little on the shallower side. We don't want a shallow chamber anytime. Coaxial नहीं है? Coaxial नहीं है? अच्छा, coaxial नहीं है तो आप ऐसा करो, मुझे एक वो ब्लेड दे दो, MVR दे दो, कर लूँगा मैं, उससे कर लूँगा. MVR दे दो, एक और ओपनिंग बना लूँगा. I have just made one side port. So can I have the swab stick please? I just made one side port as you can see here. Now I'll make another side port because they have the bimanual irrigation aspiration here. Coaxial, I think he is looking for coaxial, but sorry. अच्छा, अब हो गया मेल फीमेल. ये ले लीजिए. Just hold this. So as I was hearing Dr. Namrata, we all, I myself, along with her, we are more used to using coaxial, and in our hands it provides a faster particle aspiration if we use coaxial. But yes, we should be using all sorts of instruments, so I can use bimanual as well, and sometimes you do have to use bimanual. And so the cortical aspiration with bimanual, particularly subincisional, is easier. Now, the only thing is that you have to spend some more time with it, and particularly if you have something like this, a small epinuclear piece, it will take a little bit more time to come in. The second thing is that sometimes you can manage to remove the fiber from the same port, from the same side, but sometimes you will have to change your hand. I'm just trying to polish the capsule. What I feel is that if I change the hand, it will help me more in removing the adherent particle fibers on this side.
If they don't come, we will not hold the. So Rajesh, you would agree with me that bimanual is slower than coaxial.
No, I completely agree with you, ma'am. I have never disagreed on any occasion, actually. But yes, on this occasion, I will 100% agree. And it does take a little bit extra time. But I guess maybe people who are more used to who are more used to bimanual, they may be a little bit faster than what we can do. There is a very small plaque here which I'm trying to polish, but it's not coming. So we'll just see in the post-op period how it behaves, and then maybe we'll have to do, if the visual acuity is not great, then we'll have to do a YAG for this small plaque, because in spite of rubbing, can I have the irrigation ka? I'll just try to push some fluid from the side port. Can I have the lens, please? Lens खोल देंगे? हाँ, मैं करूँगा ना, मैं करूँगा. I'll do it. I'm just trying to do it, but this is, you can see here, this is a pacified thing. This is also a pacified thing. So it will not come with whatever you do. So can I have Hilon, please? Yeah. So I'll just put Hilon, and then I will load the lens. इधर रखिए बाबा जी. हाँ, बस. हाँ. This is the Biotech acryl cert lens, and I'll just show you how it is loaded. एक minute. So this is the, I just try to, yeah. Okay, is it focused? Is it?
Yeah,
Saline.
it
We
is
can
focused.
see it.
Yeah,
It is focused.
Saline. So first you have to put, these are the two wings, no? So you have to put some saline below the wing. Put some saline here. And you also put some saline from the tip. And then you press this one, the small plunger. So as you press, the lens first haptic gets a little folded and it becomes fixed. Now methyl cellulose. Then you have to put methyl cellulose underneath this, underneath both. And once you have put the methyl cellulose, then you close the wings. And once you have closed the wings, then you press this one so that the lens comes anteriorly. And now you just have to rotate this thing after you have put the lens in the eye. So, wait. After you have put the tip of the cartridge into the eye, actually. So I am going through a 2.2 millimeter incision, which we can. I do inject all my biotech lenses through 2.2 millimeter incision only. बाबा जी सिर को सीधा रखिए, बस. And then I'll dial it and put it behind like this, and आइए, अच्छा ये दे दो, यही है ना, bimanual ना. And now with the help of a bimanual, I'll remove the remaining viscoelastic. And this is a specially designed lens which has a asymmetric, zonal asymmetric power distribution, and it has a good intermediate distance, a defocus of 1.75 diopter in comparison to a monofocal lens which has a defocus of 0.5, and any other like some other lens like Ihans which has a defocus of 1.5. And the best place to keep the position of the haptic is superinasal and inferotemporal. So this is what I am going to do. And
So I think, Rajesh, that was an excellent surgery that you demonstrated wonderfully, and also showed the steps of loading.
Behind the IOL.
And this is the double compartment technique of viscoelastic aspiration, where you go behind the IOL and in front of the IOL.
This lens has a good intermediate defocus curve of 1.75. So the distance from distance to 57 centimeter the patient can see, and that is a reasonably good acceptable intermediate vision. And with a bilateral implantation you can have something like N8 or when you have bilateral implantation.
So thank you, Rajesh. I think we'll move to the next case. Dr. Virender, are you ready? Thank you, Rajesh, for a brilliant surgery. Brilliant surgery.
मेरा माइक ऑन करना बोलना या उनको बोल दो ही इज रेडी. नहीं वो डॉक्टर नमता पूछ रही ना, आर यू रेडी?
So Virender, can we?
माइक चालू कराओ.
माइक चालू है Virender. We can hear you.
हेलो डॉक्टर नमता, कैन you?
We can hear you. We can hear you.
Yeah, thank you. So my patient is getting trapped. I am ready.
So we have Dr. Virendra Agarwal with us from Dr. Virendra Laser Phaco Surgery Center, Jaipur. The patient is 65 years old female. We have planned for right eye cataract surgery with vision 3/60, and the cataract grade is NS3 plus cortical cataract plus PSC, and the fundus is within normal limit. Over to Dr. Virendra Agarwal, sir.
Thank you AIOS and thank you UKSOS for giving me this opportunity to perform a live surgery. And I must appreciate the Drishti Eye Hospital setup is excellent and very smooth working. The staff is very, very cooperative and they know the job, so there is no hustle fussle. And because they have changed the total OT setup, so between the two things there is a gap, but soon we will cover up. टेबल का माइक, टेबल फुट स्विच. हाँ थोड़ा सा. सलाइन डालना कॉर्निया पे. माइक्रो व्यू इज कमिंग देयर.
Can we have the microscope view, please?
Yeah, light को देखिए. Light को देखिए.
It's a magnified view. Can you just put it to full screen? Can AV put it to full screen?
It's a picture in picture. You have to full screen it.
Microscope, sorry, saline, visco.
Okay, you can start, Virender.
Yeah.
Can we make it full screen? AV team has gone for
Yeah,
that.
yeah.
So Virender, start, please.
Yeah, just starting.
So Dr. Virendra, you'll be inserting a trifocal IOL for this case.
I am going to implant a trifocal IOL from a biotech. And as I said in the morning also, my first preference is that we should use the presbyopia correcting IOLs in almost all patients who are fit. Cornea visco. There are times when patients are not fit because of the topography, macula or some. Paracan. राधा किशन जी हिलना नहीं है, अभी सुन करने की दवा डाल रहे हैं, आपको हिलना नहीं है प्लीज. कोई दर्द हो तो मुझे बोलना है, नहीं तो हिलना नहीं है. एंड इन दैट वी एक बार उठा लो बेटा, है ना. वी हैव बाइफोकल, ट्राइफोकल एंड दे आर डिफरेंट लेंसेज फ्रॉम डिफरेंट कंपनीज एंड ईडॉप्स ऑल्सो. लाइट में देखना है, हिलना नहीं है, दोनों आँख खुला रखना है. There is no financial interest, but what I am seeing that the lenses which are bifocal or trifocal with the rings are performing better than actually the EDOFs at present EDOFs. Soon we are waiting for the other EDOFs to come. Light में देखो, पैराकेन डाला. अंकल जी हिलने से दर्द ज़्यादा होगा, इसलिए प्लीज़ हिलना नहीं है. दाई नहीं, प्लीज़ हिलो नहीं. कॉर्निया पे डालो बेटा, कॉर्निया पे डालो. एक वायल चेंज कर लो इसमें. नहीं ये कॉर्निया पे आ नहीं रहा बेटा, तुम्हारा बाहर जा रहा है. नहीं आई पे नहीं कर रहा. हाँ पहले डाई बेटा, पैराकेन डाल दो कॉर्निया पे. अंकल जी कोई तकलीफ है तो मुझे बताना, लेकिन हिलना नहीं है. सुन की दवा डाल रहे हैं, आप हिलोगे तो सुन नहीं हो पाएगा. प्लीज हिलो नहीं. लाइट में देखो. चलो विस्को I prefer to use bimanual, so I made a 2 side ports, and to have the maximum effectiveness and utility of the bimanuals, I make them 180-degree apart, and it becomes slightly difficult to do phaco in this manner, but I manage myself to do it that way. Usually the angle between the chopper and phaco need to be less. MBR. There can be some controversy. The people say triplanar, biplanar, uniplanar incisions. I prefer to make the simple uniplanar incision. It never gives me a problem. And I think what all we plan and do, that they are the triplanar or something kind of that, no, 2 black one, black. The biggest advantage I feel with the MVR is that it goes in a manner the way we want. It is very predictable. 26 हिलो नहीं अभी दर्द थोड़ी हो रहा अंकल राधा किशन जी आप दर्द नहीं है ना अभी दर्द है नहीं है नहीं है प्लीज हिलना नहीं है ना हिलना नहीं है This patient is having quite good glow, but I prefer to use the dye for the purpose so that we can actually see better. And in the new setup, though it is not a very new setup in the sense the best of the equipment is available, it is better to take the help of the dye. I am a bit slow surgeon, so please bear with me. I do. I have done removal of the some viscoelastic, so there is no increase in the pressure intralenticular and intraocular. And after that, we will be doing hydro. You can see the fluid wave has gone, and we can do the checkup of the free rotation is not there. It is not a free rotation. So we will do a multi-coordinate kind of video dissection. As the previous case, the discussion was happening that the hydro procedures are very, very important for removal of a cortical matter and the sticky material. Visco. Phaco. Echo 1 power 30 या ये पकड़ना बेटा इसको पकड़ना so bottle height is just 50 centimeter. I usually use straight tip, but here I am using curved tip because that is available. देखो लाइट के बीच में देखना है लाइट के बीच में देखना है it is centered. I make trench first and then I divide and then I keep dividing. So it is not exactly divide and conquer. The vacuum is just 200. Nucleus is slightly soft, so I am trying to go more deep into it and create a plane where I can divide it. So I could make the 2 pieces.
I think the audiovisual team needs to get up and see what is happening.
Are you getting the feed there?
Yes,
we are
yes. Now we're getting it.
Okay.
So what are the parameters? Somebody can tell us. Nobody is telling us the
The
parameters.
power is 30, vacuum is 200, bottle height is 50, and flow rate is 30.
It's a slightly harder cataract compared to what we were seeing already.
It was looking more soft, so I kept the parameter low, but I am able to manage with the parameters, so I am not increasing right now. Because Only a small part of central nucleus is a denser one, rest all is soft. So I try to make the pieces first within the bag, don't take out the piece by piece and then do phaco. There are people who try to create a space, but I think there is enough space. So this is how we can do the phaco within the bag of the pieces also. Otherwise you require to come out in the anterior chamber, in the iris plane, but we can do in the bag. So that is a basic advantage. I am using Signature Pro machine and you can see the stability of the chamber. There is no surge, nothing. Yes. Now I am shifting to phaco 2 where the vacuum is 450. नहीं ये काम नहीं कर रहा है yeah. So now you can see the chamber is stable with the 450 also and bottle height is still 50 only. So what I mean to say is that the bottle height requirement is not to be there for maintaining the chamber. It is the fluidics of the machine which works. And patiently you can remove the pieces are coming to the phaco tip. I am not moving the phaco tip. So this is how you can complete. आइए बायोमैनुअल पॉलिश वाला इज इट सेंटर्ड ना
It is centered.
राधा किशन जी आराम से हो, भी कोई दर्द नहीं है आपको, हिलना नहीं है, आंख में थोड़ा सा प्रेशर आएगा. अगेन द बॉटल हाइट इज जस्ट 50 फॉर बायोमैनुअल ऑल्सो, फॉर इरिगेशन एस्पिरेशन ऑल्सो. फ्लो रेट इज 36 or Elone? No. Yeah. So as the discussion was happening in the morning that the pore size can be bigger or smaller or something, these are the bimanual cannulas designed by me, available with the Epsilon. Again, no financial interest, and you can see the cleaning is good. You can do with this also like a coaxial, but I would like to change the hands and make it more comfortable. But bimanual दूसरे वाले देना है. So this is how you can do a irrigation aspiration easily. And as Sheetal was saying that you can do a hydro. So the biggest advantage of this that it keep on doing hydro whenever required. You don't require to take out this and do another cannula. And my irrigation line you can see is having a sand blast. So through this I can do a polish. And doing with the irrigation line, it gives you advantage of a rough surface as well as the irrigation as she was saying that the fluid hydro dissection and fluid polishing. So I am using the fluid pressure, I am using that sandblasted surface and keeping the vacuum and all other parameters like IA of 34 AFR and having the 50 bottle height and vacuum of 450. So you don't require to change the parameters again and again.
The connection is gone again.
And for trifocal, bifocal, CRV type of lenses, you require to do a posterior capsule cleaning beyond 6 millimeters, so you don't have a PCO. Initially, I was doing the same thing for the anterior capsule, but later I realized that if you do anterior capsular polishing, then the addition between the anterior and posterior capsule is delayed slightly, so I stopped doing that. Visco IOL. मैं कर देता हूँ, आप कर दो. लोडिंग दिखानी थोड़ी है, रूटीन ही है ना. अगर लोडेड है तो दे दो, नहीं तो मैं कर देता हूँ. So this is a trifocal lens from the Biotech. Biotech is a company for which I am using all their lenses, monofocal, toric, multifocal, trifocal and all other lenses. I am happy that Indian company is giving a very good lens in the market at a competitive price and big advantage to the patients who can't afford and unnecessarily probably not required to go for higher price. Usually I don't load, but luckily I thought that we should show it. So that's why we are done. You can see that the smooth movement of the plunger. I'm not that expert, so the entire loop is coming straight, is not coming that folded. But still it will not have a problem because the lens material is very soft, it will not create an issue. I prefer to do a implantation with the cartridge going in through the incision rather than pushing through the incision and making the incision ragged. Irrigation line. Irrigation. And I prefer to do this rest part of the implantation with the hydro itself. इसको irrigation line को change करेंगे बेटा, कैनुला जो है ना irrigation वाला. I prefer to use the sandblasted one before IOL implantation, and after implantation I change it to plain. वो वाला सही था पहले वाला. So again with the bimanual you can remove the visco very easily in front of the IOL and behind the IOL. You can just nudge the IOL, go behind with the irrigation line, keep aspirating anterior to it. So there is no risk of doing the capsular cut as you can do otherwise with the coaxial. It doesn't mean that the coaxial is bad, but I prefer that the bimanual is an instrument along with the irrigation aspiration cannula for maneuvering many things into the eye whenever required. So this way it is a big advantage and we can do a complete cleaning.
So I think that was very nice, Virender. Thank you so much for
man.
your excellent demonstration of the case. Can we move to the next case?
Yeah, easily.
Yeah,
Thank you once again to the AIOS, UKSOS and particularly Dr. Namrata and Dr. Gaurav for arranging it so well.
Thank
so
you.
well.
Thank you.
Thank you.
I must appreciate the effort goes behind managing everything, but they have done flawless. Thank you.
Thank you. Thank you, Virender. The next case is
Just
going to
show
be
one thing for 1 second that I treat even the side port like a main incision. I do hydro from both ends of the side ports also, and that prevents many things and don't require to have a higher pressure to close the wound.
So
Thank you very much.
Thank you.
You can shift another case.
So Vardhaman is going to show us about the phakic intraocular lens implantation.
So we have Dr. Vardhaman Kankriya with us, chairman of Asian Eye Hospital, Pune. The patient is 26 years old, male, high myope with astigmatism, around 11 diopter of sphere with -4 diopter of cylinder at giving 6/9 parts vision. And the angles are open, fundus is normal, and the ACD is adequate. And we are planning to implant Icryl by Biotech, phakic IOL, toric in this patient. Over to Dr. Vardhaman Kankriya, sir.
Yeah. So first of all, thank you to Dr. Namrata ma'am, Dr. Gaurav and the entire team of AIOCMT midterm and also the Drishti Eye for the kind opportunity. Friends, this is a patient who has a very high myopic astigmatism. We are going to showcase the Biotech Icryl phakic lens. We all know that currently in refractive surgery, it is important that you master all the armamentarium of refractive surgery right from corneal and lenticular procedures. And in the lens bends procedures, whenever the myopia is beyond -8 spherical equivalent, the go-to procedure has become the phakic lenses. Icryl phakic lenses is one of the preferred choice when you are looking at a reasonable but good quality phakic lens implant. I have already made the side ports and the main port, the visco is also in the entry chamber. So I am going to showcase how this lens is loaded. This lens comes like this. There are 5 holes that you can see of 360 microns. But in terms of orientation, you have to look at this hole, which is on the left haptic here at the foot plate. So that has to be there on the leading haptic. And it is important that you load the lens quite well. Now this is easy to load compared to the other loading phakic lenses which require bimanual approach and front loading forceps. But apart from that, in this case, the loading is almost like loading a plate haptic IOL. So now this lens is in its place. I'm going to just make sure that it is absolutely nicely loaded. 1 second. So you can see that this is freely moving here. That is important for us to know. And this is the assembly in which you have to put this, the whole assembly together, and just again make sure that the lens is going in front. This is the central hole, which you can see, and it should be very well aligned. Now when we have this loading done, I'm going to go straight to the patient's eye now. You can see that already I have done the side ports and the main port. I use what is called as the angled side port incisions so that I can have an easy access to the haptics and the foot plate to tuck them in. Rahul, please look in, सीधा दिखना है बेटा आपको लाइट में. आपको लाइट दिखाई दे रहा है सामने? Yes. आपको ब्लिंक करने की कोशिश नहीं करनी है. So I'm going to implant the lens now. Yeah. सीधा ही देखते रहो बेटा. So as you can see, this has to be a very controlled and slow release. In this patient, the entry chamber is too deep actually. It is 3.6 millimeters. But even for normal patients, it's important that your loading should always be done parallel to the iris and not like IOL. So I've already implanted the lens. Can I have some viscoelastic, please? So this lens fortunately requires no rotation, but in biotech the rotation is not more than 15 degrees as against the ICL when the rotation can go up to 22.5 millimeters, and that's why it is seen that the vault prediction is very, very accurate in the biotech acrylic lenses. They're also slightly more stiffer, and that's why the studies have already shown that the what is called as the dynamic vault variations in biotech are actually lesser as compared to the other lenses.
So Vardhaman, what was your incision size for this?
This was 2.8 millimeters.
2.8, okay. And
So
I saw that you...
with the star, that is 3.2.
Right.
So these, let's say that the incision size is also smaller. So I have already tucked in the front foot plates. I am going to tuck the lagging ones, and now we have the lens which is absolutely in place. I can already see here that the lens looks good in terms of its vault.
Right.
So have the eye, please. And it is always important that you use the regular HPMC and not use the dispersive viscoelastics, because you don't want the viscoelastic to be trapped between the lens and the anterior capsule. It is important that you evacuate the viscoelastic 100% completely. The value of the central hole is very important, because the central hole achieves two things. Number one, it allows the viscoelastic to come out even behind the lens. And second thing, of course, is that you don't need a peripheral iridectomy in these patients. Fortunately, the design of this central hole is such that the halos and glare are very, very minimal. I've been lucky to have been implanting phakic lenses from 2009. And I think on an average, we do close to 80 to 100 phakic lens implants every month. Biotech acrylic lenses are something that I'm implanting for almost 8 to 9 years. From the very first time that they were introduced, we were one of the first centers also to evaluate them. And I'm extremely happy with the prediction of the vault, with the safety of the lens overall, and with the quality of vision that the patients are getting. So yeah, overall, a fantastic lens, especially for someone who would like to start the phakic lens implant journey, because they are easy to maneuver, easy to load. So they are very surgeon-friendly lenses is what I would like to say.
You don't have to relearn the injecting process, also loading process, because it loads very much like the way your intraocular lenses do load.
Absolutely,
okay, thank you so much, Vardhaman.
Thank
Can we
you
move
so
to the
much,
next case, please?
Excellent surgery, Vardhaman.
Very
Thank
nice
you
and
so
very
much, Dr.
different, because we've been seeing phaco and then
Yes, so
suddenly
it's-
the phakic lens is a very nice change.
Thank you, ma'am, for the opportunity.